Today we have an exceptional guest who's gotten up early in the morning, and I'd just like to tell you how she came to my attention through this article in the Guardian newspaper back in December, which pointed out that for Professor Ann Abbott of Monash University in Melbourne, an esteemed neurologist, it was not always easy to say or to publish what she's going to tell us about today. And I think having said that, I don't want to steal any of her time. I'm just going to turn things over to Dr. Abbott and thank her very much for joining us so early in the morning in her time.
Thank you very much for that introduction, Dr. Perry. Just going to share the screen now. Can you see that?
Beautiful.
Right. Okay. So it's quite a comprehensive talk. It will go for about an hour or a bit less, depending on how fast I go with my talking. But feel free to stand up, have a stretch during it, even look out the window if you have to. There are 4 basic areas we're going to cover. The first one is current best management of asymptomatic carotid stenosis patients, and then symptomatic patients with carotid stenosis. We're going to deal with some furfies or misconceptions regarding current best practice. We're going to look at problems with the prevailing guidelines, and then we're going to look at how things are improving for the better. So the title here is Optimizing Outcomes in Patients with Carotid Stenosis. Where are we up to in April 2021? So need to change the slide forward. How do you change this one? It's not going forward. Press on there. I'm using a different computer today, first time. So now, which button did you press for that? The mouse. Okay, all right. So just firstly say that my research along the way has only been funded by independent grants and family subsidies. Okay, now the lesion we're talking about today is moderate to severe carotid stenosis. This is arterial disease narrowing of the origin of the internal carotid artery. And knowing what to do about this lesion is important because it's common, it's easily detected, it causes about 10% of all strokes, and it identifies people at higher risk of other preventable complications, not just stroke. So, currently, there are 4 types of interventions on offer and done in the name of reducing stroke risk associated with carotid stenosis. They are endoterectomy, which is surgery, CEA for short, angioplasty with stenting, ACAS for short, transcarotid arterial revascularisation, Tcar for short, recently introduced hybrid of the 2 procedures. And we have medical intervention, which is encouraging healthy lifestyle practices and the appropriate use of medication. So in short, lifestyle coaching and medication. So procedures, particularly endoterectomy and stenting, have become a multi-billion-dollar per year international industry. This is published information from just 4 countries. The table shows you the number of procedures done per year, the proportion of asymptomatic carotid stenosis with a very wide variability, and an estimate of the total procedural cost based on American figures from 2007. So this may well be out of date now. And an indication that we have to remember the other costs of doing these procedures, the costs of the premature deaths, the cost of managing the strokes, the heart attacks, the bleeds, the infections, the cranial nerve injuries, and so on. So you can see that we're spending billions every year. Are we getting for value for money? An essential question. Right, now, first of all, we're going to talk about people with asymptomatic carotid stenosis. So these are people, and it's advanced asymptomatic carotid stenosis. They're people with 50 to 99% narrowing of their carotid artery using NASIC criteria. Generally, this is what I'm using throughout the talk. And they've never had same-sided stroke or TIA referable to that artery. So we've known for a long time that endoterectomy is inefficient for stroke prevention in people with asymptomatic carotid stenosis. And we know this from the ACAS trial. This still is the only adequately powered trial that's ever been done to compare endoterectomy with medical intervention alone. The ACST trial is sometimes mentioned in this context, but it was not like ACAS. It was a trial, a randomized trial of early versus deferred endoterectomy, not a trial of medical intervention alone. And it also included some remotely symptomatic patients. So in the ACAS trial, for every 85 patients randomized to surgery, on average during the next 12 months of follow-up in that study, 3 patients had a stroke or possibly a death, but mostly a stroke, prevented from the endoterectomy. But that was at the expense of 2 patients who had a stroke or possibly a death caused by the procedure. And for the remaining 80 patients, the surgery had no effect on the risk of stroke. They weren't going to have a stroke with or without the procedure. And if I was a patient, I would consider this highly inefficient and not particularly attractive as a treatment option. And we have to keep in mind that patients were randomized into ACAS 28 to 34 years ago, and a lot has changed with medical intervention since then. We should also keep in mind that there was only one subgroup of asymptomatic carotid stenosis that was shown to benefit overall, because they didn't all benefit, from endoterectomy. And if you consider the ACAS trial here, but if you also want to consider the ACST trial and early endoterectomy, overall, it was only generally fit men aged less than 75 to 80 years who had at least 60% asymptomatic carotid stenosis using NASIT criteria, but they also had to have a life expectancy of at least 3 to 5 years, satisfy all the trial inclusion and exclusion criteria, and the 30-day rate of stroke or death from those trials had to be less than 1.7 to 3%, depending on which trial and which result you consider. We'll talk about that a bit more later. But overall, even for those men, the benefit from endoterectomy was small, 1% per year stroke risk reduction. Women with asymptomatic carotid stenosis did not benefit from endoterectomy in ACAS, and there was no clear statistically significant benefit for any subgroup of asymptomatic women in the ACST trial. So why do we do so many procedures, if any, on women? We also should keep in mind that outcomes from endoterectomy are usually worse outside randomized trials. For example, this is a meta-analysis of 30-day endoterectomy stroke or death rates in 47 high-volume asymptomatic carotid stenosis patients registries. It was only by about 9 years after ACAS was published in 95 that the average 30-day stroke or death rate averaged 2.3% in these registries. And that was the overall 30-day stroke or death rate in ACAS. And it was about 15 years, I can't see all my typing at the moment, but it was about 15 years after ACAS was published, yes, 15 years, that the 30-day stroke or death rate reached 1.7%. And that was the 30-day stroke or death rate in ACAS without the angiographic risk. And that is the standard we should have accepted at the beginning, because we don't use angiography these days. That 3% figure that we've been using as a standard for 30-day stroke or death rates with procedures came from the ACST trial and is less appropriate. But moreover, ever since those trial results had been published, these procedural standards have been becoming increasingly outdated and excessive due to advances in medical intervention. So all of this here, really, certainly above these lines, and also probably from the baseline, it pretty much represents net patient harm. We also know that transaortic stenting, so stenting going across the aorta, usually from the groin, but possibly from the arm, is worse than endoterectomy. It causes about twice as many peri-procedural strokes or deaths than endoterectomy. And this is a table summarizing the main results from the randomized trials of stenting versus endoterectomy with respect to asymptomatic carotid stenosis patients. They're all in orange font to indicate that they were underpowered to compare the 30-day stroke or death rate between these procedures. But overall, the direction of effect in these studies was towards twice as many peri-procedural strokes or deaths with stenting. And also the confidence intervals indicate that with larger sample sizes, if you rolled out these trials to routine practice, it's highly likely that you'd get up to maybe 2.5 times as many strokes or deaths with stenting compared to endoterectomy. This comparison of randomized trial results and procedural outcomes with stenting versus endoterectomy for asymptomatic carotid stenosis reached statistical significance in a meta-analysis of all the trials published in 2019. The excess risk of stroke and death from stenting is seen in registries, and it's not compensated by the peri-procedural rate of myocardial infarction. We'll talk about that a bit later as well. Now, the harm from stenting patients with asymptomatic carotid stenosis is durable. It's measurable for as long as we've followed up patients in these randomized trials. And again, the orange font indicates underpowering for long-term outcomes and comparisons. But the comparison reached statistical significance with the CREST-1 data when both asymptomatic and symptomatic patients were combined. More strokes with stenting by 10 years of follow-up using Kaplan-Meier analysis and risk estimates. The ACAS Tcar trial also individually underpowered. So what about this new procedure, Transcarotid arterial revascularisation? Well, unfortunately, it's only being assessed in registries and compared against other carotid procedures. As far as I know, there are no planned randomized trials comparing Tcar with current optimal medical intervention. And with such a management plan, there's no way you can establish a routine practice indication for this procedure. To establish a routine practice procedure for a routine practice indication for any procedure, you need to make comparisons with current optimal medical intervention used on its own. So what about medical intervention? Well, that was the subject of my PhD, in a way. I was asked to look at embolic signal detection using transcranial Doppler and work out whether the detection of embolic signals identified patients at particularly high risk of same-sided stroke, patients that might preferentially benefit from endoterectomy. And these were the overall results from that study. There were 202 patients. The mean follow-up was nearly 3 years, and the average annual rate of first ipsilateral stroke was only about 1%. And also the rates of embolus detection were very low. On average, we had to sit there and wait 6 hours for one embolus to go by. And it still is a manual process. There's no reliable automated process of detecting these emboli in asymptomatic carotid stenosis patients because the emboli are soft in their signal and there are so few of them. And this is a process I wouldn't wish on my worst enemy. It's so time-consuming and difficult. Overall, we found no significant relationship between the detection of at least one embolic signal and the subsequent rate or risk of ipsilateral stroke or TIA. So at the time, it was implied to me this was a negative result. Time to go back into routine practice. No more research to be done, move on. But I was rather fascinated by this low ipsilateral stroke rate. It was 2 to 3 times lower than expected based on the literature available at that time when we planned the study. And I was also seeing, as I was doing this study over a number of years, seeing a number of patients in our study pass through without any strokes. And we weren't giving them particularly aggressive medical intervention either. At the same time, across the road in a private hospital, there are a number of patients going through with asymptomatic carotid surgery having endoterectomy, and a high proportion of them were having procedural complications, mainly stroke or heart attack. But I did wonder, maybe medical intervention has improved and we don't need to do so many procedures these days. So I went on and did a postdoc. I wanted to find out whether, in fact, the rate of same-sided stroke has reduced over time just with medical intervention. So my first systematic review and meta-analysis was published in 2009. I published it on my own because no one wanted to have a bar of it. And the studies at that stage went out to those published to 2009. I updated this meta-analysis in 2017 with studies that went out to 2013. The method with each meta-analysis was the same. Simply a Medline and bibliography search for suitable studies, which were prospective, which involved at least 100 patients with 50 to 99% stenosis, asymptomatic at baseline. The studies could be randomized or not. You don't need a randomized trial to accurately measure a rate. But the patients had to be given medical intervention alone, and I concentrated on the first event of interest per patient where possible. Sometimes the literature was not very clear on that. I certainly separated rates derived from raw data, simply the number of events, the number of patients, the mean or average, the mean or median follow-up as a percentage. And all of my rates refer to this raw data because that's the most comparable method across studies. Kaplan-Meier rate estimates are not really rates, they are estimates, they're projections, and you can use any follow-up period duration you want to make them. And as you go out beyond the average follow-up period, more uncertainty exists, and it's very hard to compare studies directly using Kaplan-Meier risk estimates. So we're not going to talk about those in this talk any further. We used weighted linear regression analysis, which means that the studies with the largest sample sizes had the biggest effect on the regression line. And we accounted for multiple comparisons on the same data set. So this is a summary of the results. These are the studies that satisfied those basic criteria for sound methodology. The ones in white font were available for the 2009 meta-analysis, and the ones in yellow font were added later. You can see that the first reliable measurement was actually published in 1984, and that was well after the ACAS study was underway. So in other words, we were randomizing patients to procedures before we had any idea of what could be achieved with medical intervention alone. And unfortunately, we have repeated that mistake over and over, and we are still doing it now. This is a figure summarizing the latest meta-analysis published around 2017. A variation of the same analysis was also published in 2020. So each orange diamond represents a study's result with the sample size next to it, and the stroke rates, ipsilateral, are simply plotted by publication year. You can see in the middle of that the orange regression line going down and the very tight confidence level intervals around it, confidence limits, I should say. So we can be very certain that the average annual ipsilateral stroke rate has fallen significantly over time since the first publication in the mid-1980s. There's been a 1.7% absolute risk or rate fall and a 67% relative rate fall, round to about 0.8% per year in the most recently reported studies. And that's 2 to 3 times lower than seen with stenting or endoterectomy in previous randomized trials. And it's also highly likely that we can do much better than that with current optimal medical intervention, because the medical intervention described in those most recently reported studies was poorly described, but it's out of date already. notice that the latest reported stroke rates around about 0.8% are about 50% lower, 56% lower than what was seen with medical intervention alone in ACAS, which was published in 95, highlighted by that little yellow square in the middle. But we're still using the ACAS results to dictate what goes on in routine practice and what's written in the guidelines. This is inappropriate. This discovery of the significant fall in stroke rate with medical intervention alone has been independently validated by several groups now, including Ross Naylor. And at least up until 2009, when I did this analysis regarding baseline risk factors, there were significant changes. For example, the proportion of patients diagnosed with high cholesterol at baseline went up over time, probably because we've become more aware of cholesterol during that time, but also our definition of high cholesterol became more sensitive. But interestingly, the average age of the patients at baseline went up over that time period between 84 and 2009 by an average of 5.5 years. So this means that these patients are living longer, stroke-free lives with just medical intervention. I think this is very good news. Also, over that time period between 84 and 2009, the proportion of patients diagnosed with ischemic heart disease and atrial fibrillation at baseline was lowered. I think this is an indication that perhaps, again, patients with better medical treatment, lifestyle and medications, they are living longer lives without symptoms or manifestations of arterial disease. And in support of that as well, the proportion of current smokers at baseline fell significantly by 14%, an indication that those public health campaigns are getting out there and working, and people are giving up the cigarettes, thank goodness. All right, so given that information, all of that information we've just gone through, we can now estimate that about 0% of patients with asymptomatic carotid stenosis, like those that went into ACAS and the ACST trial, about 0% of them overall now could possibly benefit from a carotid artery procedure. This is because the average annual ipsilateral stroke rate is now, based on those in meta-analysis, around 0.8%. About half the strokes occurring in the distribution of the lesion are not due to the stenosis. The average age of diagnosing the lesion in those meta-analysis studies was 70 years, and the average survival was 10 years. Medical intervention has improved some more since 2013, and procedural stroke and death rates cannot always and everywhere be zero. So in other words, we have passed the era of an overall procedural benefit for individuals with asymptomatic carotid stenosis. Now, I thought this was great news. Great news. Stroke prevention has become more effective, less invasive and cheaper, and we don't need to admit all these people to hospitals and let them go through all of those procedural complications. So, in summary, the current best management for patients with asymptomatic carotid stenosis is medical intervention alone because of its improved efficacy. It also reduces the risk of all arterial disease complications, including a risk of heart attack, which is caused by the procedures. And patients who now benefit from an additional procedure are rare, if existent, and remain unidentified. We'll talk about that some more later. So that's the first sort of part covered. If you want to have a little break, we are going to move on to symptomatic individuals with same-sided carotid stenosis. I no longer use the term symptomatic carotid stenosis. Sometimes I do it by habit. It's such an entrenched term, but it's actually biased towards procedures. Because when you hear the term symptomatic carotid stenosis, you think, oh my God, it's the carotid stenosis has done something. We've got to do something to that lesion in particular, and that means procedures generally. But in fact, in about half the patients with stroke or TIA who have the same-sided carotid stenosis, there's another easily identifiable possible cause of their stroke or TIA. So the correct terminology is actually to refer to the patient as symptomatic and they have carotid stenosis. And then we'll think about other options. We'll defocus on the procedures. So we've known for a long time that endoterectomy is inefficient for stroke prevention in symptomatic patients with carotid stenosis. And we know that from the pooled results of NASIT, the ECST trial, and the veterans study. For every 53 patients randomized into those trials, on average, and I think that figure there is covered up, but I think it's 6. There are 6 little faces there that on average had a stroke or death prevented over the next 12 months of follow-up in the trials. But that was at the expense of 3 patients who had an immediate stroke or death caused by the procedure. And for the remaining 46 patients, the procedure, in this case endoterectomy, had no effect on their risk of stroke. They weren't going to have a stroke with or without the surgery. And patients were randomized into these trials 27 to 40 years ago, even longer with respect to ACAS, longer ago, even more outdated. Limited subgroups of symptomatic patients had an overall benefit from endoterectomy in those trials. They had to have a life expectancy of at least 3 to 5 years, satisfy all the study inclusion and exclusion criteria, not have near carotid occlusion, and they had to fit into one of these 3 groups. They had to be women with 70 to 99% stenosis and have endoterectomy within 2 to 3 weeks of their last same-sided stroke or TIA. Or they had to be men with moderate stenosis and have endoterectomy within 2 to 3 weeks of their last same-sided stroke or TIA. Or they had to be men with 70 to 99% carotid stenosis and have endoterectomy up to about 3 months after their last same-sided stroke or TIA. But most of the benefit for these men was in the first 2 to 3 weeks after their last same-sided stroke or TIA, and the benefit fell rapidly over time. In addition, the 30-day stroke or death rate for these people was less than 6%, approximately. Other patients, subgroups with symptoms have not been shown to benefit from endoterectomy or any carotid procedure compared to medical intervention alone. Now, we know now too that transaortic stenting is worse than endoterectomy for symptomatic people with carotid stenosis. This is a summary, again, of the relevant randomized trials of endoterectomy versus stenting in symptomatic people. The ones in white font were adequately powered on their own to make the comparison, whereas the ones in orange were not. But overall, and even in a lot of these individual studies, it was clear that the stenting was causing about twice as many strokes or deaths in the peri-procedural period compared to endoterectomy. It's much easier to show differences in procedures in symptomatic people because the event rates, such as stroke rates, are higher than in asymptomatic people. So this is why we're seeing significant differences in symptomatic people, much easier in many ways compared to asymptomatic carotid stenosis patients. But overall, the trends are usually in the same direction, or the effects are in the same manner overall. Also, this excess risk of heart attack, stroke and death with stenting was not compensated by the peri-procedural rate of heart attack. I will go on to talk about that a bit later. The excess risk of stroke and deaths with stenting has been seen conclusively in meta-analyses of randomized trials, and it's also seen quite clearly in registries. So the harm from stenting in terms of stroke and death is durable. It's measurable for as long as we've followed up patients in the randomized trials. Again, the ones here in white font were adequately powered on their own, but in orange were not. And it's, again, difficulty when you're getting out to long-term follow-up, but in CREST-1, we see statistically significant excess risk of stroke with stenting compared to endoterectomy when the symptomatic and asymptomatic patients were combined. So particularly vulnerable to the stenting risk are older patients, those who are recently symptomatic, women, those with certain carotid anatomical features, those with tandem lesions, those where more than one stent is used, and those who have their stent in low volume centres and outside trials. And this does cover most patients with carotid stenosis. When people say that it's okay to stent younger people or any other subgroup, it's usually based on underpowered. It's always, as far as I can tell, based on underpowered studies. So stenting has not been shown to be beneficial for any patient with carotid stenosis. We're only seeing evidence of harm where studies have been adequately powered. Tcar, well, what about Tcar for symptomatic patients? Well, again, it's only being assessed in registries and compared with other procedures. There are no planned randomized trials against current optimal medical intervention, and an indication for Tcar for symptomatic patients could not be established with this methodology. What about current medical intervention alone for symptomatic patients? Well, unfortunately, there's not much recent data. We haven't challenged the symptomatic randomized trials as much as we've challenged ACAS results over the years. It hasn't really been retested because we keep assuming the procedures are great and are indicated. But we do know that all past randomized procedural trials involving symptomatic patients are very much outdated. And it's most likely that that 6% 30-day stroke or death rate standard that we still use is now excessive. And symptomatic patients are the priority for stroke risk stratification and procedural studies, not the asymptomatic patients. And we are focusing on asymptomatic patients in these trials at the moment, which is also another mistake. So overall, the best management for symptomatic patients at the moment, this is my interpretation, is that they should all get current best medical intervention, and some should be offered early and expert endoterectomy, but only for the three so-called proven subgroups that I mentioned earlier, which were mostly men and mostly had to get the operation done within 2 or 3 weeks of their last same-sided stroke or TIA. But patients should be informed that the evidence for the procedural benefit is up to 40 years old and really should have been retested several times since. It's nothing for us as clinicians to be proud of in offering these procedures. Now we're going to move on to the next part. I'd like to tell you about Furfies. Furfies, which are used to make stenting appear similar to endoterectomy and make endoterectomy, stenting and Tcar appear indicated. Now, firstly, I was going on about Furfies for quite a while and not realizing that my audience had no idea about what I was talking about, because a Furfie is Australian slang for a rumor or an erroneous or improbable story, but usually claimed to be absolute fact. Furfies are usually heard first or second hand from a reputable source, such as the New England Journal of Medicine, the Lancet, the guidelines, your boss, and until discounted, they are widely believed. Now, I mentioned, where Furfies might come from. It might be a little bit uncomfortable for people to think of it, that the Furfies might be coming from these reputable sources, but we always need to check the validity of what we are told if we are going to move forward and improve outcomes. It doesn't matter where we're told it from, we always need to challenge and check on our own, not just blindly follow. All right, the first Furfie I'd like to mention is this one, just simply leaving out the 30-day procedural risk period where all the strokes and deaths, excess strokes and deaths from stenting occur. So proponents of this Furfie say that stenting and endoterectomy are similar after a successful procedure. They simply leave out the peri-procedural period and talk about what happens after the first 30 days. But this is totally invalid and ridiculous. You can't offer and have a procedure done if you're a patient unless you actually go through the periprocedural period. So just to emphasize that, the harm of stenting is immediate and durable. This is a figure from the CREST-1 study, their long-term follow-up. It's a combination of asymptomatic carotid stenosis patients and symptomatic patients. And you can see that the rate of stroke and death is immediately higher in the stenting group, and it remains that way. So in other words, these patients are having their stroke, some of them are dying at the beginning, and that remains that way forever. So the patients have died prematurely, they're no longer around, or they have to live long-term with the effects of their stroke. The second one is the heart attack furfie. Proponents of this say that stenting and endoterectomy are similar because the excess strokes with stenting is compensated by the risk of clinically defined heart attack with endoterectomy. Well, this has been busted. This is a table that summarizes the 30-day rate of stroke, clinically defined heart attack, and death in the randomized trials of stenting versus endoterectomy, where they were published. And this is a combination of symptomatic and asymptomatic carotid stenosis patients. You can see that overall, the 30-day strokes were twice as high with stenting, 202 versus 99. And stenting, if you look to the right there, also was associated with a lot more deaths, 32 versus 21. But endoterectomy was associated with about twice as many clinically defined heart attacks. But those heart attacks sort of pale into insignificance because the strokes and the deaths were so much more common than the heart attacks. And overall, stenting caused 1.6 times more strokes or heart attacks with or without deaths than endoterectomy. And if I was a patient, I would consider that significant. And at least with respect to symptomatic patients, this comparison of stroke, death, and heart attack was statistically significant, with more with stenting in studies just looking at the symptomatic patients. The third furfie is the most severe stroke furfie. Now, this has come from the International Carotid Stenting Study, which has been the largest randomized trial of stenting versus an endoterectomy for symptomatic patients. And it's quite clear that in that study at 5 years, any stroke was nearly 2 times more common with stenting compared to endoterectomy, and that was statistically significant. They sort of couldn't get around that. But the proponents of this furfie say that the procedures are similar, as the most severe strokes with a modified Rankin score of at least 3 were about twice as common, were about the same, I think, or about the same. So the first problem with this is that all strokes are disabling. You can't just forget about the modified Rankin score patients with a 1 or a 2, because even those patients can be significantly disabled. And we must keep in mind that the modified Rankin score is only an overall estimate of how well you can carry out your activities of daily living, like walking on your own, feeding yourself, getting yourself cleaned. It does not take into consideration other things, more complicated things like being a neurologist or being a surgeon. But even people at a score of 2 can't carry on like they used to in simple things. So you can't just forget about them. The second problem was that this study was actually underpowered to look for a statistically significant difference with respect to the most severe strokes. So if we work from the bottom of this iceberg here, the study was powered sufficiently to look at the difference between the appearance of new DWI lesions after procedures. Stenting caused significantly more. It was also powered to look at the rate of stroke of any severity, and stenting caused significantly more. But it wasn't powered to compare the rate of the most severe strokes. The hazard ratio is about 1, but if you look at that 95% confidence interval, it goes out to about 1.7. I can't quite see it now, but it's about 1.7. So this implies that if you rolled out this study from the small number of patients that were in it, about 1,600, relatively small. If you roll that out to routine practice around the world where you get hundreds of thousands of patients, it's highly likely that stenting would cause up to 1.6, 1.7 times more of the most severe strokes than endoterectomy. Again, underpowering. 4, the late disability furfie. This one again has come from the International Carotid Stenting Study. As mentioned in that study, by 5 years of follow-up, any stroke was more common with stenting. That was statistically significant. But proponents of this furfie say that the procedures are similar because the prevalence of late disability with both procedures was about the same. But this is busted. This is what they've done here. Well, first of all, we know, and they've acknowledged, that within 120 days of the procedures, stenting caused significantly more strokes or deaths than endoterectomy, nearly twice as many. But then they've looked at disability of any cause at 1 and 5 years after procedures. So evidently disability of any cause, not just stroke, could be arthritis of your knee and you can't walk because of that. Any cause of disability is very common in this elderly population. And in this study, it involved 60% of patients at 1 year and about 70% by 5 years. So what they've done here with their furfie is combine the excess disability caused by the procedural strokes from stenting and endoterectomy with any form of disability. And this is a way of statistically camouflaging that excess risk with stenting compared to endoterectomy. It's not a way of getting rid of it. Now, the 5th furfie I'd like to mention today, and there are plenty more, but the 5th one I'd like to mention is this relatively recent one, proposed and put out there, encouraged by some new guidelines, particularly the European Society of Vascular Surgery, was published in 2018. So here they're saying, we're just going to operate on the asymptomatic carotid stenosis at particularly high risk of ipsilateral stroke despite medical intervention. Now, they've listed quite a number of things there. I've listed 9 that have come straight from that, guideline. And they have actually given endorsements for endoterectomy and even stenting for average surgical risk asymptomatic carotid stenosis patients, if at least one of these criteria or other undefined criteria are present. Now, the one at the bottom there, 80 to 99% stenosis, was not explicitly mentioned in that guideline, but it's commonly used in clinical practice. People say, oh, we just operate on them. We just stent them because they preferentially benefit from our procedure, which is, of course, unproven and unlikely. So just to summarize the problems with that, that policy that's being encouraged is that individually, all of those markers are quite common. Not all have actually been shown to identify people with asymptomatic carotid stenosis at higher risk of ipsilateral stroke. But where that has been shown, the risk of stroke is generally too low to indicate that the patients are going to benefit from a carotid procedure. And none of those markers have been tested using current optimal medical intervention. So all previous rates of stroke based on those parameters are excessive compared to what can be achieved with current medical intervention. None of the markers have been tested in randomized trials. And as a group, these markers cover just about all asymptomatic carotid stenosis patients, well above that 0% figure that we started with that are most likely to benefit from a procedure now. And I would think that those markers are probably better used now for symptomatic patients rather than asymptomatic patients, because the symptomatic patients still have a higher risk of ipsilateral stroke than the asymptomatic ones and could possibly benefit from a procedure in addition to current optimal medical intervention. So what about these prevailing carotid randomized trials, are they going to establish an indication for a procedure in modern practice? Well, I think, unfortunately, or not unfortunately, depending on which way you want to look at it, it's unlikely that they will establish a procedural indication for any carotid stenosis patients for the modern era. I'll go through my reasoning, looking at individual trials. So the ACAS trial is a randomized trial from the UK comparing stenting versus endoterectomy in asymptomatic carotid stenosis patients. There is no medical intervention, only arm. And as I said before, you can't establish a procedural indication until you've shown you provided benefit over and above current best medical intervention alone. So that one's out. Looking at CREST-2, now to their credit, they are comparing endoterectomy and stenting with medical and medical intervention on its own, but only in patients with asymptomatic carotid stenosis and patients similar to those that went into ACAS. So overall, I don't think they're going to show a procedural indication because we already know that these procedures are most unlikely to provide an overall benefit in asymptomatic carotid stenosis patients like that these days. The ECST2 trial, also to its credit, has a medical intervention only arm. And it's also including some symptomatic patients, also to its credit. But unfortunately, the symptomatic patients that are randomized are going to be very low stroke risk patients, similar to those of the asymptomatic carotid stenosis patients. And the asymptomatic carotid stenosis patients going in there are also similar to the ACAS patients, pretty much general and unselected. So again, highly unlikely that they'll show a procedural benefit. And this fourth trial, the ACTRIS trial, again, a randomized trial of asymptomatic carotid stenosis patients, to its credit, has a medical intervention only arm. And also to its credit, they're going to risk stratify people before they go in. So they're going to be selecting out patients with those high risk markers, embolus detection and plaque morphology based markers and so on. But unfortunately, I think they're going to be underpowered because they haven't first measured the risk of ipsilateral stroke with those markers with current best medical intervention alone. They're basing their study on outdated information, and the risk of stroke in relation to those markers is going to be lower. So their sample size is going to blow out if they're trying to compare with procedures. So unfortunately, if you're a proceduralist, I don't think these trials are going to help. So the next part of our talk here is about guidelines. What do the guidelines say in view of all of this evidence and the things I've been talking about? Well, we did a critical comparative audit of the guidelines with respect to procedures for carotid stenosis, and we published it in 2015. And we are doing an update now, and things haven't changed. So what I'm talking about refers to the publication in 2015, but things haven't changed yet. In 2015, at that point, we had identified 34 eligible guidelines with procedural recommendations for patients with asymptomatic carotid stenosis or for symptomatic patients with carotid stenosis. And they were published between 2008 and 2015. They came from 23 regions or countries, and they were in 6 languages. Unfortunately, they were all troubled by procedurally biased recommendations. Let's just look at the recommendations for asymptomatic carotid stenosis patients. Patients were divided into average surgical risk patients with 50 to 99% carotid stenosis versus high surgical risk patients. High surgical risk was defined based on their anatomy or significant comorbidities, and sometimes it wasn't defined. So they didn't define what high risk was, which is not good. So looking at those 2 subgroups, endoterectomy was endorsed for average surgical risk asymptomatic carotid stenosis in just about all guidelines, despite no current evidence of benefit. Of more concern, perhaps, is that stenting was being endorsed in over half of the average surgical risk patients and about half of the high surgical risk patients, despite overall evidence of harm and certainly no evidence of benefit. Hardly any of the guidelines recommended medical intervention alone. The symptomatic patients and the recommendations, these patients were divided into average surgical risk patients, like those that went into the previous randomized trials, NASIT, ECST, and they were subdivided into those with 50 to 69% moderate stenosis and 70 to 99% high grade carotid stenosis. And then we had the high surgical risk patients, again, sometimes totally undefined what high surgical risk meant, which is not good, 50 to 99% stenosis. Now, all the guidelines recommended endoterectomy, endorsed it for average surgical risk patients, despite no current evidence of benefit. And they're also recommending it well beyond patient subgroups shown to benefit in the randomized trials that we were talking about before, those 3 groups, well beyond that. Stenting was also being endorsed in over half of the guidelines for the average surgical risk patients. And in 80% of the high surgical risk patients, the guidelines were recommending stenting. And this is despite overwhelming evidence of excess risk of stenting compared to endoterectomy and no comparisons with medical intervention alone. There's great confusion in the guidelines regarding terminology. So they use different words and different symbols to describe the nature of the recommendation. So whether they're recommending something should be done or not, or could be done. Also, lots of different words and symbols used for the nature of the evidence. The evidence was great, it was poor, it was frankly bad. And then they're using the same words and the same symbols sometimes to refer to the recommendations or the evidence. So very confusing when you're trying to compare guidelines. But more importantly, were the serious omissions. So in just about all of the guidelines, they didn't bother to define asymptomatic carotid stenosis or symptomatic patients. Those definitions should have come straight out of the relevant randomized trials, not hard. They didn't define average or high surgical risk. And look at that, just about all the guidelines didn't define the procedural standards that should have, again, come straight out of the randomized trials. What is the 30-day stroke or death rate that you should be aiming for based on those randomized trials? Not given. Just very general terminology used, not precise. A lot of the guidelines failed to include any recommendations with respect to medical intervention. And for many guidelines, it was hard to access them, no public access. Another big problem with the guidelines is complete confidence in randomized data alone in terms of ranking evidence. So if it's randomized evidence, it's great. We should be using it. That's what they say. If it's not randomized trial evidence, well, it's always going to be inferior. But this sort of approach favors harmful procedures because we do have some randomized trial evidence that these procedures benefited some patients, even though that evidence was way out of date. But they cling to that because we haven't re-challenged, we haven't done the randomized trials again. So the concept that randomization is best reinforces the procedural bias and encourages us to keep making the same mistakes over and over. My conclusion is that the contemporary international guidelines, all of them, there's no one perfect one available at the moment, that the procedural endorsements are based only on outdated information. The endorsements of procedures are not limited to patients who benefited in past randomized trials. They over-rely on randomization to rank evidence. They understate the hazards of procedures, particularly stenting. They understate the value of medical intervention. And there are many forms of bias which encourage dangerous and costly procedures. They're also generally poorly organised, inconsistent, and difficult to access. So the overall situation with respect to carotid arterial disease management around the world has been one of chaos and loss of tremendous proportion. The carotid procedural industry that we talked about at the beginning, huge financially. It's built on the accumulation of errors over decades. If we start at the bottom there, errors such as errors in thinking, such as that randomized trials are applicable everywhere and always, that men and women benefited from procedures in trials, that medical intervention and populations stay the same forever, that randomization is always best, that stenting and endoterectomy are equivalent, that stenting is best for high surgical risk patients, that guidelines and leaders are always correct. But times are changing. Stroke prevention has become more effective, less invasive and cheaper. And that's the great news to take away from all of this. And hats off to the investigators, the patients, so many people, public health advisors, policy advisors, who have made this impact over the decades. Procedural rates are starting to fall by up to 50 to 100% in America and the US and Europe, at least. Not sure about the other regions. There are improved guidelines, particularly in Australia at the moment, compared to that meta-analysis, but they're still not perfect. And they're probably the best in the world at the moment that I know of. But soon we will have improved international guideline because we are creating the first evidence-true guideline for carotid stenosis management, and we are doing that under the auspices of the International Union of Angiology. In that guideline, we are going to accurately and fairly rank scientific evidence with respect to its relevance in current routine practice. We're going to take into consideration, with respect to a piece of evidence or a trial result, for example, whether randomization was actually needed to address the clinical question that the clinician is faced with. As mentioned earlier, you don't need a randomized trial to accurately measure a rate. You don't need a randomized trial to accurately measure a very low stroke rate, for example, with asymptomatic carotid stenosis and show that a procedure is just not indicated. We will also take in consideration whether all reasonable treatment strategies were compared in the study, whether the study is still current, whether the target population was adequately defined, whether the primary outcome was adequately defined, and whether it's even relevant to the clinical question that the clinician faces here and now, whether the study was powered for clinically significant differences, whether follow-up was adequate in the trial, whether the results have been independently verified in other studies or particularly in local routine practice. It's no good just assuming that your 30-day stroke or death rate is going to be less than the target, whatever that is, if you don't measure it in your own place. Also, new design trials with a medical intervention only arm have started up. Now that is good news because prior to recent times, we're only comparing procedures in randomized trials, and that's highly, highly biased. Because if you do a randomized trial just involving procedures and conclude that a procedure is indicated, then of course you're wrong because, you're probably wrong, or you may be wrong at least, because you haven't compared your procedure with current medical intervention on its own. So I've mentioned those randomized trials, but we think that it's unethical to do a procedure on just about every patient. There are a few exceptions, the symptomatic patients in those 3 subgroups I mentioned earlier that did have an overall benefit from procedures in the randomized trials. But for everyone else, we think it's unethical to do a procedure. And it's more important for us to measure outcomes with current best medical intervention on its own. So that's why we're starting up the CASCOM study. It's a non-randomized, multinational study just to look at stroke rates and rates of other complications in symptomatic and asymptomatic patients with carotid stenosis given current best medical intervention on its own. But I am open to people joining in the campaign to change practice for the better. And if you are interested in any way in helping with the guidelines, with the study, please contact me. And that is my last slide.
Perfect timing. Great. Thank you, Dr. Abbott. That was fantastic. So much amazing information. I'll get straight to the questions. one that was echoed by two people. Continuing on the discussion about medical therapy, can you comment on what constitutes appropriate medical therapy, with specific comments regarding ASA, clopidogrel, maybe rivaroxaban plus ASA, statins for all patients, target LDL levels, and any other aspects of medical therapy? That would be great.
Right. Well, medical therapy is a complicated issue. It has evolved across many specialties over the decades, and that's caused quite a lot of confusion. But to try and summarize, firstly, the antiplatelet therapy, because that's the main difference between symptomatic and asymptomatic patients. So there is indication to use a combination of aspirin and clopidogrel for the first 2 to 3 months after stroke or ischemic stroke or TIA in symptomatic patients, and maybe aspirin after that. But actually the evidence for long-term aspirin is pretty much, as I'm finding, almost non-existent. So we're probably overusing aspirin in symptomatic patients, and it does carry risk. There's no indication for antiplatelet therapy in a person who's completely asymptomatic, so they never had stroke or other arterial disease manifestations. But aspirin therapy is judged based on the symptomatic status of the patient. So for TIA and stroke, I've just covered that. It might be different for legs, for instance, symptomatic legs, or the heart, or stents. That covers antiplatelet therapy. There's currently no proven indication for anticoagulant therapy with or without aspirin therapy for patients with carotid stenosis, whether it's symptomatic or asymptomatic. Recent studies have come out, like the COMPASS trial, targeted to symptomatic people with particularly heart disease and leg arterial disease. If you look at the subgroup analysis, you'll see that there was no statistically significant benefit from a combination of aspirin and clopidogrel for patients with carotid stenosis, and they've very, very poorly described their carotid stenosis patients and how they were selected and whether they already had heart disease, symptomatic heart disease, or symptomatic leg arterial disease. So don't go down that route, please. Just exposing people to unnecessary risk. With respect to lipid lowering and blood pressure lowering therapy, similar for asymptomatic and symptomatic patients with carotid stenosis, basically you go as low as you can, as long as the patient can tolerate the therapy. So as low as you go with LDL, for example, a combination of the maximum tolerated statin therapy with ezetrol to get it down, that should be pretty much routine. There's no unsafe low limit of LDL. With blood pressure, again, targets are coming down because there's benefit from lowering blood pressure. As long as the patient can still stand up and they're not getting dizzy, just go as low as you can. And the other agents, again, encouraging regular exercise, healthy weight, control of sugars, not smoking, no illicit drugs, avoiding alcohol excess, also all very important. And the combination of that package is highly effective at reducing your risk of stroke and other arterial disease complications and other health problems like cancer. Next question.
Great, thank you very much. The next question relates to a definition for asymptomatic carotid stenosis. How would you articulate that?
I think we should go with the terminology. It says asymptomatic, no symptoms. And ACAS was based on patients with, and that's still the dominant trial that we use when we're justifying procedures. And I think the terminology used and definition in that trial was highly appropriate. So carotid stenosis and no previous clinically defined stroke or TIA on the same side.
Okay, great. And maybe we'll finish with the last question about the large multi-center RCTs that you spoke of that didn't have a medical treatment arm and how they may not add to the science. How did they get ethics approval? Not sure. Okay.
That was
based on a
answer.
series of bad assumptions. Yes. Okay. I wanted to say thank you on behalf of the Therapeutics Initiative, but I'll pass it over to Dr. Perry to conclude the session.
If you can hear me, yeah. It lived up to the reason why Dr. Abbott, you received the Maddox Prize named after the former editor of Nature. And I think the implications for all kinds of other evidence and how we possibly know whether we're current in evidence are profound. So I expect there will be many people wanting to return to our website to watch this lecture at a time that's more convenient to them. And I thank you very much for presenting for us today.
I just mentioned that I've got to write all this up for a publication in the Frontiers in Neurology, open access, over the next few weeks. I'm a bit behind because I'm writing grant applications, but it's pretty much going to be word for word. So if anyone wants this in writing, I hope to supply it by the end of this year.
We can link it also to our website, to the video when we post it. Thank you again.
Okay, thank you.